So thank you so much for joining me today on today's office hours on stomach acid, friend or foe. So before we get into what stomach acid does and whether it's helping or hindering, just wanted to go through a few basics about stomach acid with you. And one of those basics is, where is most of the stomach acid produced? So it is produced in the stomach, not surprisingly, by something called the hydrogen potassium ATPase. And it's sometimes referred to just as a proton pump. So that's the machinery within the stomach that pumps out stomach acid. And it's primarily parietal cells. Okay, you have different cells in the stomach. You have oxyntic cells, parietal cells. Gosh, this is taking me back to my medical school pathophysiology. But yeah, the parietal cells are about 80% of cells in the stomach, mostly in the upper part of the stomach, and they produce the acid. So the first thing I want to point out is we have stomach acid for a reason. This was not a mistake when we were evolving, that we created the ability to, and the mechanism for producing stomach acid as part of the digestion of food as an accident, and oops, we messed up here. And I'll tell you that stomach acid is probably the most critical part of digestion. Why? Because it helps all the other processes of digestion to work optimally. So for example, when we think of digestive enzymes, so we'll take amylase and lipase, which are two of the enzymes produced by the pancreas. And as you probably know, lipase breaks down fat and amylase primarily breaks down starch. And we also have salivary amylase that's reduced from the saliva glands. But the bulk of amylase and lipase are released in the pancreas. If you don't have a certain level of acidity, those enzymes won't work properly, which means that you're going to get carbohydrate and fat problems with digesting them, and possibly malabsorption. So I also want to distinguish between maldigestion and malabsorption. Malabsorption refers specifically to the fact that certain nutrients are not being absorbed through the lining, that little fishing net lining, permeable membrane of the gut. So malabsorption suggests that they're not being absorbed properly, whereas maldigestion is a more generic term, more general, that refers to there's a problem with digestion somewhere along the way. It may not necessarily be absorption. It could be the churning up of the food into chyme, into the small particles in the stomach. It could be something else. So absorption is referring specifically to the nutrients moving through the digestive membrane, and maldigestion just means a problem. So for example, if you don't have enough stomach acid, that can lead to malabsorption, but it can also lead to maldigestion because there are other more general things that go wrong also. So one of the issues with stomach acid is it allows these digestive enzymes, not just amylase and lipase, but others also, to work optimally. You need that acidic pH for those enzymes to work properly and for us to be able to properly assimilate the food, which means that even if we're eating a fantastic diet, if we are not properly assimilating the nutrients, where, it's sort of all for naught, or we're not getting as much benefit from those nutrients as we could and should be. So there's digestion. I also obviously cannot get through office hours without talking about the microbiome. It's leaping out of my mouth before I can even say the words, right? So what does stomach acid have to do with the microbiome? Well, as many of you know who've been participating in these office hours with me for a while now, is that we have a natural gradient from mouth to anus, from north to south, in our digestive tract when it comes to the amount of bacteria and the different type of bacteria too. But if we just talk about the amount of bacteria, we have low levels of bacteria higher up in the GI tract, in our esophagus and stomach and small intestine, for example, than we do in our colon. So as we go from the top of the digestive tract all the way down through the small intestine and down to the colon and to the very end of the colon, we see a dramatic increase in the amount of bacteria. Why is that? Well, from a functional point of view, it's because most of the fermentation of things happen, of the indigestible dietary fiber that I'm so fond of and that I recommend we all eat a lot of. Remember, it's indigestible or poorly digestible. It's not broken down well in the small intestine where a lot of the other food is. It floats on down to the colon, and in the colon is where that large high concentration of bacteria, large population, break down those fibrous products and ferment them into what we call postbiotics, metabolites like short-chain fatty acids, etc. Okay, so that's why we have a lot of those bacteria down in the colon. And we have fewer bacteria higher up in the stomach. Now, the stomach is by no means sterile. And even despite this acidic milieu, lots of bacteria, both sort of not so helpful, like Helicobacter pylori, as well as more helpful, can survive and thrive. But one of the things that happens when we block stomach acid is that we change this gradient. We mess with this gradient, and this gradient is there for a reason. Again, this is not an accident that you have low levels of bacteria higher up in the GI tract and high levels down below. This is very intentional and really serves an important purpose. So what happens now, this is a time to introduce PPIs, proton pump inhibitors. So that's the little purple pill. Some of the brand names include Prilosec, Nexium, Prevacid, Protonix. There's lots of them on the market now. And these drugs are amongst some of the most commonly prescribed drugs in the world. Over 100 million prescriptions for PPIs per year in the US, right? That's a ton. That's a ton of prescriptions, and somewhere around 20 to 30 million people chronically taking them. And we'll get into, what happens when you block stomach acid and what happens when you naturally have less stomach acid, and, we'll decide friend or foe. And of course, that's a very individual decision. But let me just chat for a minute about proton pump inhibitors. So these drugs work remarkably well. They block that stomach acid pump. They shut down that hydrogen potassium ATPase. Now, in contrast to histamine blockers, H2 blockers, that was a class of drugs we had when I was in medical school, was when proton pump inhibitors came on the scene. That's how long ago I was in medical school, in the late 80s and early 90s. And at the time we had H2 blockers. So those were drugs that you probably know as Zantac, Pepcid, etc. Now, as you probably know, there was a problem with Zantac. A few years ago, it was discovered that it had a carcinogen in it, NDMA, nitrosodimethylamine. Forgive me if I'm messing that up, but NDMA. And NDMA is a known carcinogen. And so there was a black box warnings eventually taken off the market. But Pepcid, which the generic is famotidine, still seems safe to take from what we know. Now, all of these drugs have side effects. There's no drug out there that doesn't have potential side effects. It doesn't mean you will necessarily experience that side effect, but there are side effects. So the side effects for H2 blockers, diarrhea is a common one. Some people have muscle aches, fatigue. Some people have constipation, abdominal pain, but they're generally milder. The side effects of proton pump inhibitors, well, the main thing it does is it blocks stomach acid. So what are the side effects of not having stomach acid? When you block stomach acid as effectively as you do with a PPI, you are creating a pathological condition called achlorhydria, okay, which means no stomach acid. And that rarely occurs on its own. A condition called hypochlorhydria, which is low stomach acid, can occur as a result of something called atrophic gastritis and a couple of other conditions. And as we age, we have less stomach acid. I'll talk about that in a minute. But the PPIs create achlorhydria, no stomach acid. Well, what does that mean? Well, first of all, it messes with digestion, right? So we see that the fat-soluble vitamins, vitamins A, D, E, and K, cannot get properly assimilated. So you have problems with potentially vitamin D, and that can lead to osteoporosis, osteopenia. So there is an association with increased fracture risk over time for using these drugs long-term. But when we look at the body, and, I'm fond of saying, like, the gut is your engine, right in the middle of your body. And then you have the brain, and you have the kidneys, and you have the lungs, and you have all the different organs. So when we look at long-term achlorhydria, not having stomach acid, we see potential problems with vitamin B12. We see potential problems with iron. We see kidney problems, we see cardiovascular problems, we see bone problems, we even see brain problems, and in terms of cognitive decline. And that is because all of these organs rely on the nutrients being assimilated properly in order for the cells in these organs to do their business. And if you are messing up nutrient delivery, like right at the top of the pyramid, you're creating a problem, you're going to have downstream effect. And that's why there's so many different problems that are associated with chronic long-term use of these drugs. Now, I'm not talking about, you're on these drugs for 2 weeks or even for 6 weeks or 8 weeks. We're talking about people on these drugs for several months or years. Another thing that's very much on my radar is this question of viral susceptibility. And it's on my radar because I just wrote a book called The Antiviral Gut. And really delving into the research was fascinating. So one of the first things that, and literally this was one of the things that kind of lit a fire onto me and made me say, gosh, I got to write a book about this. There's just too much stuff that people are not aware of. One of those things was in July 2020, when an article was published. This was a study that was done between Cedars-Sinai in Los Angeles and University of Michigan in Ann Arbor, a collaborative study. Population-based study, so looking at people out in the real world, and they looked at 53,000 people, and they wanted to answer this simple question: does blocking stomach acid increase your risk of contracting COVID? That was a fairly basic question. And for those of us in the GI world, we are not surprised by the answer to this, right? Because we know that stomach acid denatures viral protein, renders it inactive. So stomach acid is one of your main defenses against not just viral illnesses, but other enteric illnesses also, other illnesses that affect the gut. So there are foodborne illnesses or other infectious things that get in through the gut. And we know stomach acid can denature the proteins that are part of these infectious organisms and protect you. And so we've seen for decades, for example, when there's an outbreak of a viral illness on a cruise ship, like norovirus, rotavirus, or something like that, people who are on proton pump inhibitors will be more likely to get sick. So that's not new. But what was new from this study was looking at how high the risk was. So let me tell you about that risk. In people taking a proton pump inhibitor once a day, they had a 2-fold increased likelihood of testing positive for COVID. In people taking a proton pump inhibitor twice a day, their risk was 3 to 4-fold higher. And that surprised even me. And I'm not a real fan of these drugs. I was very surprised by that data. And as I said, that was one of the it was an impetus for me to say, wow, I think I started asking people, I would be at a picnic or something, and I would say to somebody who was not a physician, hey, did you know that stomach acid protects you against viruses? Do you know how that works? And they would be like, no, I didn't know how that worked. So I realized as I started polling people that people weren't making that connection between stomach acid and protection from viruses. And then here was this huge study of 53,000 people clarifying, just exactly what that risk looked like. So we've talked about digestion and absorption. We've talked about how the digestive enzymes work. We've talked about the other organs relying on these nutrients and how when you sort of mess it up at a high level, it can put those different organs at risk. We've talked about the bacterial gradient and the microbiome. We've talked about protection against viral illnesses. There's more, but I'll stop there. And I'll spend a minute or two, because I know we're going to have a lot of questions today, but it seems I'm talking fast because we're doing well for time. I want to talk about the opposite side of this, because I know a lot of you probably have questions about apple cider vinegar. What if I don't have enough acid, etc. The first thing I want to tell you is that as we age, stomach acid levels decrease, and that is normal. That's not a disease. And what we have seen in medicine is we have seen the medicalization of aging. Wrinkles, not a disease. Bone loss as we age, not a disease. Now, accelerated bone loss is different, right? So we're sort of age matching what is a normal amount of bone to lose as we get older. And if you're in that range, not a disease. If yours is accelerated for some reason, then there might be cause for alarm. But we lose bone mass as we age. We lose muscle mass as we age. We get wrinkles as we age, and we secrete less stomach acid as we age. Again, not an accident. There's a reason for that. The requirement is less. So if we were to line up 100 people over age 60 and measure their stomach acid, we would find that they have less stomach acid than 100 people we randomly lined up who were 30. And again, that's normal. If we were to line up 100 people over 60 and measure their bone mass, their bone density, it would be less than 100 people age 30. So, we have this way in medicine and in the pharmaceutical world and in the supplement world of medicalizing these natural processes and trying to convince people that you have a disease and you have a problem and you need to take something. And so I'll stress again that it is an accelerated level of this that maybe will give you, is cause for concern, but not the general process because it's supposed to happen. And so when we look at, there are studies looking at people over 60, and they find that this hypochlorhydria. So let me here distinguish it. Hypo means low, but achlorhydria means no stomach acid. Hypochlorhydria, it's sometimes abbreviated HCH, is this, again, condition of lower stomach acid than normal. And if you look at different studies, depending on what study you read, that number will be between 20 to 30% of people over 60. But what I want to point out is that a lot of these people have low stomach acid because they've been taking antacids or they've been taking proton pump inhibitors. There are other drugs too that can affect the gradient, but those are the two that would affect it most profoundly, really the three. So H2 blockers, antacids, and proton pump inhibitors. And so if you have low stomach acid levels because you've been taking proton pump inhibitors in the past, that's not really a disease, right? That's a manifestation of the drug you've been taking. So when we look at these studies, they're lumping in a lot of people. And we also have data showing that proton pump inhibitors are amongst the most commonly prescribed drugs, period, and particularly in the population over 60. And in that population, there's a lot of legacy prescribing where somebody may be having reflux or have an ulcer, they get put on it, and then it gets continued as a legacy without there being a clear indication for it. And that's particularly concerning to me because what are people over 65 also more prone to? Becoming sick from viral illnesses, right? So there was a great study that was done from the UK, and they looked at, this was even before COVID, but they looked at viral susceptibility in older people to the flu and found there was a direct correlation between people over 65 taking PPIs unnecessarily and coming down with viral illnesses and being sicker, going from a flu to a pneumonia requiring hospitalization, et cetera. So if you have relatives over 65 in particular, who may be on a PPI and maybe don't have a super strong indication for it, you may want to just say to them, hey, maybe you should check with your doctor about whether you really need this drug, okay? And what would the actual indications be for a PPI? Well, chronic I'll just say most people on a PPI in America are on it because of reflux, and reflux alone is not an FDA-approved indication for a PPI. What are the FDA-approved indications? It doesn't mean now doctors can use it for, however they see fit, and you can get it over the counter, but I'll tell you what the actual indications are that have the data behind them. Chronic refractory GERD, GE reflux disease, gastroesophageal reflux disease, in people who have failed diet and lifestyle recommendations. So right there, you see that this is not a first line recommendation. It's not, oh, you have GERD, take a PPI. It's you have GERD, diet and lifestyle changes first. If you try everything and it doesn't work and you still have chronic symptoms, then it's appropriate to consider a PPI. Prevention of bleeding, and people are at high risk for bleeding. So somebody who's on a blood thinner, who has had recurrent bleeding ulcers, somebody like that, that's an indication. Something called Zollinger-Ellison syndrome, ZE syndrome, which is hyperproduction of acid. So I will tell you, and I've said this before, there are only about 300 people in the US who have overproduction of stomach acid. Everybody else who has reflux has inappropriate opening of that sphincter, the lower esophageal sphincter, that allows the stomach acid to come up into the esophagus. So Zollinger-Ellison syndrome is a real disease, but rare. So rare that there's a study section at NIH for it. And when I was full-time at Georgetown, we had a joint appointment to NIH. And we saw some really interesting diseases. And we saw diseases that you would typically never see in your entire clinical career. And Zollinger-Ellison is one of those diseases because it's so rare. How rare? About 1 in a million people in the US, which is why I said maybe about 300. Okay, 350 people in the US may have ZE syndrome, Zollinger-Ellison syndrome. but we saw a bunch of people with ZE at NIH when we had this joint appointment, because that's where they all go for care, because it's so rare and there's not a lot of expertise in the general community. So with this hyperproduction of acid, these patients need to have their stomach acid levels blocked. So that is another indication. Barrett's esophagus, which is a pre-malignant condition of the esophagus, those patients is an indication, particularly if a lot of the esophagus is removed. While I'm on the topic of Barrett's esophagus, let me point out that as with real estate, when it comes to stomach acid, location, location, location. Stomach acid is supposed to be in the stomach. When you have inappropriate opening of that lower esophageal sphincter and it rises up into the esophagus, it causes all kinds of problems. Why? Because the esophagus is lined with a certain type of cell lining called a squamous cell. And squamous cells are not resistant to acid. The stomach, because the parietal cells in the stomach are churning out acid, the stomach is lined with specialized columnar cells, columnar epithelium. And columnar cells are resistant to acid. So when you have that lower esophageal sphincter and it is opening inappropriately, it's opening inappropriately because you're eating late at night. And by late at night, I mean after the sun sets, when the stomach is less active. So you're eating late at night, you're overfilling your stomach, you're eating too much fat, or you're doing a combination. You're having a high fat food like ice cream at night. So stomach is not emptying, fat takes longer to digest, stomach is full for longer, the sphincter is likely to pop open. So overfilling, eating late at night, too much fat, all of these things, eating and then lying down so you don't have the benefit of being upright to help things move down through the stomach. All of these things can lead to reflux, right? And so what reflux really is inappropriate opening of that sphincter that allows acid to rise up from the stomach where it's supposed to be, digesting the food, into the esophagus where it's now damaging to the lining of the esophagus and it causes symptoms. And over time, with persistent reflux, you can have this condition called Barrett's esophagus, where the squamous cells start to change through a process of something called intestinal metaplasia, and they start to look more like stomach cells. And in fact, when I do endoscopy, what I see is that the normal pale pink lining of the esophagus now looks a more beefy red like the stomach. So you can see it with the naked eye, but we always confirm it with a biopsy, and the pathologist tells us it's Barrett's esophagus. And if you just have 1 centimeter or 2 of your esophagus with Barrett's, that's not so much a risk for esophageal cancer. But if a large amount of your esophagus is being replaced by this other type of cell as the cells change due to recurrent exposure to acid, that's a problem, and that may be an indication for long-term proton pump inhibitor. But basic reflux, not an indication for a proton pump inhibitor in the absence of, trying these dietary and lifestyle changes. Okay, so let me see. We've got a bunch of questions, so let me take a little break here. Let me draw breath, and we'll come back. Okay. Oh, thank you, Andrew. Yes, Andrew says he's looking forward to my presentation at the PCRM conference in August and meeting me in person. Please come find me. So PCRM, I always have to give a shout out to Neil Bernard and the folks at the Physicians Committee for Responsible Medicine. They're a fantastic organization located right here in Washington, D.C. They do great advocacy work for plant-based diet. And for example, one of the things they're working on now is a petition to get known carcinogens off hospital trays. Seems like a good idea, right? You're in the hospital is feeding you known carcinogens. So they're trying to get bacon and sausage off the trays of hospitals, which is, absolutely important work. So yes, Andrew, look forward to meeting you too. Okay, so somebody is telling us, I took a PPI for 16 consecutive years. I've been entirely off them for 4 years. Excellent, Jennifer. I'm glad to hear it. Can I offset my fracture risk by taking vitamin D and ensuring that this level increases? My last vitamin D level was 45 about 11 months ago. In other words, can fracture risk be reduced by stopping the PPI? Absolutely, Jennifer. And I would tell you that if you stopped the PPI 4 years ago, your vitamin D level is a healthy 45. Now, what I want to tell you is that fracture risk doesn't just correlate with vitamin D, right? Vitamin D levels are one of the things that inform fracture risk, but not the only thing. And weight-bearing exercise is important too, and all this other stuff. But what I will tell you, Jennifer, is that if you stopped the PPI 4 years ago, I would not worry about the fracture risk increasing, right? And in fact, that fracture risk should be decreasing, especially with an adequate vitamin D level. So good for you for getting off that PPI, and thank you for sharing. How do you know if you have enough stomach acid? Okay. The first thing I want to say, Gina, to you and everyone else, is if you are on a site on the internet that is telling you, here are the, and there are a lot of them, here are the signs of low stomach acid. The first thing you will notice is that all of these signs are very nonspecific. Typically, they will say, do you feel bloated? Do you still feel hungry after you eat? Are you, do you have a lot of flatulence? Do you have stomach upset, et cetera? So these are all very, sorry, I'm spitting. These are all very nonspecific signs and symptoms. None of these are signs and symptoms that you can make a diagnosis of. Okay, so again, just like hyperacidity, rare. Now, low acidity is less rare, but the main cause of low acidity is having been on a drug to block stomach acid. So Gina, if you have not been taking a lot of NSAIDs, a lot of antacids, NSAIDs, now the drug, not great for the GI tract. I really am very protective of my organ and your organs, your GI tract. So NSAIDs, PPIs, these are drugs, I like to keep them away from the GI tract if I can, because they're very potentially harmful. Of course, there are times when you need them, but judicious use again. So Gina, if you have not been blocking stomach acid, there's really very little reason to be concerned about low stomach acid, okay? And I want you to be wary of basing this on symptoms, because the symptoms are nonspecific. If you are truly concerned because you're having other concerning symptoms, you should go to a gastroenterologist for an evaluation for that. And then we can talk about apple cider vinegar and, pros and cons. But let me get through these questions. Okay, acid, hiatal hernia, and eosinophilic esophagitis. My doc says PPIs for life. I've actually been off them since January and don't want to restart trying diet. Well, good for you, Karen, but I always want to remind you, as much as I'd love to be, I'm not your doctor. This is educational. This is not medical advice. So do follow through with them, but do get a second opinion. I'm glad you mentioned EOE, eosinophilic esophagitis, because it is one of the conditions that is on the list as an indication, potential indication for acid blockers, but by no means does a diagnosis of eosinophilic esophagitis mean you have to be on lifelong proton pump inhibitors. So one of the things I always do when I diagnose eosinophilic esophagitis, and for those of you who may be less familiar, sorry about that. It is a condition where the esophagus looks normal to the naked eye, but when we biopsy, we see a high level of eosinophils in the lining, and it can actually cause choking. I don't have it. I just have a little mucus. It can cause symptoms of choking and food getting stuck and all kinds of different symptoms. And we think that eosinophilic esophagitis, it's really an emerging condition, but is a response of the esophageal lining to something that you're being exposed to, that you're reacting to. Eosinophils are cells that are associated with allergy, typically. So the first thing I do when I diagnose somebody with eosinophilic esophagitis is I send them to my good friend, Dr. Mark Skarupa, who's a wonderful immunologist and allergist in the area, who has an interest in this. I mean, he has an interest in hives and all kinds of other things. And Dr. Skarupa will typically do testing to see, is this person allergic to something? So he might do blood testing, patch testing, a combination. And one of the things I have seen frequently in my patients, and it doesn't mean everybody, but soy is one of those common allergens that can be associated with eosinophilic esophagitis. I'm sorry about that. I kept my husband up all last night coughing. I just felt like something got stuck and I can't get rid of it. A frog. So what I would suggest to you, Gina, is that you, sorry, not Gina, Karen. What I would suggest to you, Karen, is that, think about getting a second opinion, or just pressing your doctor and saying, look, I understand your position, but I've also heard that eosinophilic esophagitis can be associated with allergies to different foods. Is there an allergist or immunologist that you like who you could refer me to do some testing to see? Because what I do in those patients is I follow them. So I send them. Sometimes Dr. Skrupa is able to, find the cause, sometimes not. If he is able to find the cause, obviously I have them eliminate those foods, and I will redo their endoscopy 6 months or 9 months or a year later and see, are the eosinophils still there? Or if we don't find anything, I'll have them do an elimination diet and see if their symptoms go away. And when their symptoms go away, I'll rescope them and biopsy them. So, I very carefully follow up to see what's going on with the eosinophilic esophagitis. And I also want to point out, Karen, that it is not uncommon for people with reflux to have EOs, as we affectionately call them in gastroenterology, in the esophageal lining, right? But to make a diagnosis of eosinophilic esophagitis requires a certain number of eosinophils per high power field by the pathologist. So you also want to be very clear with your gastroenterologist, did I have the kind of eosinophilia that's just suggestive of reflux? Or did I have eosinophilia of a level to make a diagnosis of eosinophilic esophagitis? And I say that just because I have seen people come in saying, I have a diagnosis of eosinophilic esophagitis. And when I've had my pathologist review the slides, they'll say, no, this doesn't meet the criteria. This is just irritation. So that's an important point too. Okay. Remember Carafate? Of course I remember Carafate. Sucralfate. I use a lot of Carafate still in patients. What would be the appropriate use of that drug? So Sucralfate is another name for Carafate, is a drug that basically, it's an older drug, even older than H2 blockers, I think, that essentially coats the lining of the esophagus. And so that was what we had before PPIs for ulcers, esophagitis, et cetera. And I will still use that drug, for example, in people who have something called pill esophagitis, which is a condition where you're taking large pills, and there's some sort of known pills that do it. Potassium supplements are one, other pills that are large, and they get stuck. There's a little notch in the esophagus where you see that it's the aortic bifurcation. Obviously, the aorta and the esophagus are separate organs, and the esophagus, you swallow food and it goes down, and the aorta is carrying blood. But there's a part of the esophagus anatomically where the aorta bifurcates into two, and there's sometimes a little notch in the esophagus there, like a little indentation, and that's a sometimes common area for these pills to get stuck. And they can sit there, and often these pills are corrosive to the lining of the esophagus, and they can cause an ulcer. And even after the pill is long gone, and antibiotics are another one that can do it. Doxycycline. So people taking doxycycline for acne or for Lyme disease or things, it's a common precipitator of pill esophagitis. But, when I do an endoscopy, or we can diagnose it on a barium study by the radiologist where they drink barium, and we see the little ulcer there. And long after the pill is gone, because an ulcer has been created, people often have symptoms. So that's an indication where I will often use Carafate, for example. Okay, so it would be more short-term for esophageal irritation, for erosions. If you had, Gina, a serious ulcer in the stomach, I don't think Carafate would be the best choice. In that case, a proton pump inhibitor would be a better choice, but short-term, right? 2 to 6 weeks, depending on how severe the ulcer is. DGL, licorice, essentially. Is it good to use? Well, Joyce, what I'll tell you is it's not harmful. And so if you use it and you feel better, I think it's okay to use a little bit of that because it doesn't have a lot of harmful side effects. So I've skirted around apple cider vinegar, and I will tell you that the reason so many people, I think, feel better with apple cider vinegar is so many people are taking drugs that actually drop their stomach acid. So, a good solution, if you're taking a drug to suppress your stomach acid and you don't really need it, a good and obvious solution would be to stop taking that drug. But let's say you do stop taking that drug and it takes a while for your stomach acid levels to come back to normal. So you sort of functionally have hypochlorhydria. You could try a little apple cider vinegar. Very important to dilute it. Okay, because straight apple cider vinegar can erode the enamel of your teeth. It can even damage your tongue and esophagus if you're drinking it straight daily. So you want to dilute it, teaspoon or a tablespoon in a glass of water. Some people also drink it with a straw to protect their teeth. I'm not sure that's necessary. And you want to get ideally organic, unfiltered, a sort of raw apple cider vinegar. The one that's sort of cloudy is considered more potent than a filtered pasteurized apple cider vinegar. Okay, so terrible acid reflux for 2 years now. How do I know if I have too little acid production, too much, or if it's appropriate for my age? Again, what I want to point out is that 99.999% of people who have acid reflux has nothing to do with how much stomach acid they have. It has to do with the stomach acid coming up inappropriately into their esophagus and damaging the esophagus. So we don't make any recommendations for measuring stomach acid if you have reflux. We do make recommendations depending on how long the symptoms have been going on for, how severe they are, for taking a look at the esophagus with an endoscopy, seeing if your esophagus is damaged, and perhaps measuring that sphincter pressure. That's something that we can do, not with an endoscopy, but with another test called esophageal manometry. And we insert a tube down and while you're awake, and we leave it in typically. So 2 tests, esophageal manometry, a 24-hour pH monitoring. Those, excuse me, 2 tests can give us a ton of information about acid levels, etc. So let's start with the esophageal manometry. And I'm glad you asked this question because it triggered me to talk about this. And it's a really important aspect of evaluating this whole issue of stomach acid. So the esophageal manometries, they put a little pressure gauge down right around the lower esophageal sphincter, and they measure what the pressure in the lower esophageal sphincter is. And we know what the normal pressure is supposed to be. So we see, is your pressure low? Do you have low resting pressure, which means that your sphincter, instead of, holding things tight between the esophagus and the stomach, it's loose. And now acid is just coming up all the time, right? So the esophageal manometry can be very helpful, and it can be helpful on the other side for a condition called achalasia, where the sphincter is too tight, but that's a whole other set of problems. So we're not going to muddy the waters with that. So that's a manometry. And then the other part of usually deciding what's going on from a reflux point of view is something called a 24-hour pH monitoring. And in the old days, as in a few years ago, we used to put a tube in down the nose into the esophagus, and we would literally tape it to the patient's cheek and send them home with it for 24 hours. Now we have all kinds of little cool probes and doodads. So we have a device that you can put an endoscopically clip right there to the bottom of the esophagus, and it sits there for 24 to 48 hours, and it measures the acid levels, and then it just detaches and you poo it out. Very cool. So there are all kinds of different ways that we can measure. Measuring one-time stomach acid is completely useless and not helpful. Why? Because the stomach acid is going to vary based on whether you're in a fed or a fasted state. So stomach acid levels are very different when I'm doing an endoscopy and you've not had anything to eat or drink for 8 hours. And they don't tell me anything compared to stomach acid, what's happening after you've eaten, etc. So we need to look over a 24-hour period of time minimally, and looking at you during that time when you're upright, when you're horizontal for sleeping, when you're eating, after you've eaten, postprandial, after the meal, before you've eaten, etc. So we look at that. It's sort of like a glucose, right? One glucose measurement on its own, not super helpful. What if you just ate a candy bar? What if you haven't eaten in 12 hours? But 24-hour pH monitoring over a 24-hour period of time tells us what is that lower esophageal sphincter and what is the esophagus specifically seeing in terms of acid over a 24-hour period of time. And for example, if you have a big meal and then lie down, we're going to see that typically that acid monitor show a spike. But when we do this, we have people keep a journal, a notebook, and they'll say, okay, I ate here, now I'm going to bed. And then we see, okay, person ate a large meal at 9 p.m., went to bed at 10 p.m., lying horizontal now. So now the acid can come up into the esophagus. It's not like when you're virtual. It's not like when you're vertical and it has to sort of travel up against gravity. When you're lying down, it's easy for the acid to get into the esophagus. So if we see in your little journal that, oh, you ate a, cheeseburger at 9 o'clock and then you lay down at 10 o'clock and now we're seeing an acid spike in your distal esophagus, we're like, okay, that is physiological. That's not pathological. So we very carefully analyze, and there's software to analyze what's going on with the acid secretion over this 24-hour period of time in relation to meals, to fasting, to position, upright versus horizontal, etc. And then we are able to give a score based on that suggests, yes, you're having significant acid reflux. No, you're not having acid reflux. Yes, you're having some permutations, but they're physiological. They're not pathological. So that would be the best way to know what is going on. And is this even acid reflux? Because one of the things I see in my practice commonly is SIbo, small intestinal bacterial overgrowth, and dysbiosis in general, causing these symptoms. And the irony is that acid blockers, just like antibiotics long-term, can cause dysbiosis. So I see people taking more and more of an acid blocker, switching to different ones. And, when we sort of roll our sleeves up and do some excavating, we realize, oh, it's the drug that's causing the problem, not treating the problem. So I would recommend a good evaluation there and ask them about an esophageal manometry and a 24-hour pH monitoring test, and particularly for you, the 24-hour pH. Okay. Hi, I'm not understanding why the requirement for stomach acid decreases as we age. Environmental risks continue. Okay, so our bodies change as we age. So just as hormone levels fluctuate, right? Our estrogen levels drop. We don't have the same estrogen levels at 70 that we do at 30 because of, we're not reproducing, because of fertility, et cetera, and other things. It's not just stomach acid, it's other enzyme levels, kidney function changes, cardiac function changes. Our bodies are aging, our organs are getting older. And part of why we think that those stomach acid levels drop is also our food requirement drops, right? As we get older, a 70-year-old does not have the same nutritional requirements as a 15-year-old. Their cell replication is not as active. So they don't have the same nutritional requirements. And so that's why a lot of these digestive enzyme levels drop. Now, can they drop too fast? Sure. But when you see the environmental risks continue, the stomach acid levels are really falling as we age in response to what's going on in our body internally. Now, you're right, the environmental risk, as in viruses, are still out there. But as long as we are not blocking stomach acid, even though we have less stomach acid as we get older, if we're not interfering with it, remember we have hypochlorhydria, not achlorhydria, not absence of stomach acid. So in terms of environmental risk, and I'm glad you brought it up, I'm assuming you're talking about risk of something like viruses. In the absence of meddling with what remaining stomach acid we have, we should still be able to keep ourselves safe from viruses as we get older from that point of view. Okay. Our immune function also decreases as we get older, right? And ostensibly, we need our immune system to also keep us safe from environmental factors and environmental risks. So it's not that we have a non-functioning immune system as we get older. It's less reactive. It's less responsive. So yes, that's bad news in terms of mounting an immune response to a vaccine, but it's good news in terms of like having less autoimmune diseases as we're older. So it's less reactive. Okay. Oh, thank you, Rose. Rose says she loves my books. Thank you so much for that. Does a baking soda test for stomach acid work? No, that's not helpful. Okay, I have a hiatal hernia and have what my doctor calls persistent mechanical regurgitation. So for those of you who may not know, a hiatal hernia means the stomach comes up, the stomach joins, or rather the esophagus joins the stomach higher in the chest than it should, higher up instead of lower down. Normally, that lower esophageal sphincter, that junction between the esophagus and stomach, should occur right around the levels of your diaphragms. With a hiatal hernia, it's higher up. And the higher up it is, the larger the hiatal hernia. So what the hiatal hernia is referring to is the amount of your stomach that is up in the chest above the diaphragms as opposed to below the diaphragms. So you have persistent mechanical regurgitation. No problems during the day, only regurg at night. I've been on PPIs for 16 years. My goodness. I'm going to be 81 in 2 months. Happy birthday when it comes. and she wants me to consider hiatal hernia surgery. I have grade A esophagitis, chronic gastritis, a Schottky ring, which is a web of tissue that sort of can cause some narrowing of the esophagus and cause food to get stuck. Is a biopsy necessary to diagnose Barrett's? Yes, 100%. You cannot diagnose Barrett's without a biopsy because it is a histologic diagnosis. She said that I do not have Barrett's. Okay. Now, what I will say is that you need a biopsy to confirm Barrett's. We can see Barrett's with the naked eye because it looks different. But to say for sure that redness we're seeing in the esophagus is Barrett's, we do need a biopsy. But if you don't have any of those changes, you don't need a biopsy to say you don't have Barrett's, okay? If that makes sense, you need a biopsy to confirm Barrett's when we see it. But if we don't see any of the changes of Barrett's, you don't need a biopsy to say you don't have it. Okay, so if she said you don't have Barrett's, I would be good with that. Your schedule for esophageal manometry, excellent. 24-hour pH test, excellent. Those are two tests we must always do. I highly recommend before any consideration of esophageal surgery. Sleep on a wedge. You stop eating at least 4 hours before bed. She told me to get a second opinion. The second opinion does not recommend surgery. What is my risk of esophageal cancer if I do not have hiatal hernia surgery? Very low, because the main risk of esophageal cancer, of this kind of esophageal cancer, is Barrett's esophagus. Okay, now there's other kinds of esophageal cancer and the risk factors of smoking and exposure to carcinogens, et cetera. But I assume you're talking about this. If you don't have Barrett's esophagus, despite having the hiatal hernia, the mechanical regurgitation, and the Schottky ring, in the absence of Barrett's, those are not risk factors for esophageal cancer. So first of all, there's some great signs here for your gastroenterologist. I give her 2 thumbs up. Even though she recommended surgery, she told you to get a second opinion, and she's scheduling you for the esophageal manometry and the 24-hour pH. And the second opinion is saying no surgery. I'm very conservative. I took my dad to a neurosurgeon a couple of years ago for a problem he was having, and it was this neurosurgeon who's the chief of neurosurgery at Georgetown, really wonderful man. And he said to my dad, who is also a surgeon, he said, there are old surgeons and there are bold surgeons, but there are no old, bold surgeons because you learn over time. So at 80, you're 80, going to be 81 in a couple months. Very low risk for esophageal cancer, no increased risk because of no Barrett's. I would say, let's see what that esophageal manometry and 24-hour pH tests show. And I really like that opinion of the other doc who says no surgery. But again, I'm not your doctor. But I want to tell you that I think your gastroenterologist is being very thoughtful about this in recommending these tests and sending you to someone else. So I feel like you're well tended. Okay. All right. An 80-year-old woman, would it help to increase my stomach acidity to reduce my viral risk? No. We don't have any indication that adding more acid is more protective. Even though you're 80 and you have less stomach acid than you had when you were 30, in the absence of a diagnosis of atrophic gastritis, which you would know about because you would probably have had symptoms, gone to see your doctor, can be asymptomatic, but rare. It can happen as an autoimmune phenomena. But in the absence of taking a medication, your acid levels should be adequate to protect you. You don't need massive amounts. You just need a little bit, right, to denature that viral protein. I love that so many of the people on this call are over 60 and over 65. And I love that you're actively engaged in your health and you're asking these fantastic questions. So good on you. Okay. Does drinking a little bit of apple cider vinegar each day help with acid reflux? We have no randomized controlled trials that apple cider vinegar helps with reflux. Now, if you have acid reflux and you are taking a drug like a proton pump inhibitor, and you are continuing to have symptoms, and potentially your symptoms are a result of blocking stomach acid, not because of stomach acid coming up in your esophagus, and you take apple cider vinegar and you feel better, that should prompt you to have a conversation with your doctor about maybe tapering off the PPI because maybe it's the low stomach acid or no stomach acid as a result of the drug that's causing the problem. But we don't have, I'm very much believe in science. And even though anecdote and experience is important too, having those studies is key. And to date, we don't have any randomized controlled trials showing that apple cider vinegar improves reflux. I wish we did, but we don't. And so it's left to anecdote. As I've said before, it's a fairly low risk thing to try, assuming you're diluting it and you're not, overdosing on it. Watch that teeth enamel. So again, if you're trying it and you're like, gosh, this makes me feel better, great. I mean, I drink water in the morning. It makes me feel better. It's fine. These are not harmful things. But again, I'm concerned about people taking proton pump inhibitors and the drug being the cause of their symptoms, because what they're really experiencing is the bloating and the discomfort from having bacterial overgrowth as a result of the drug. And so again, if you've been diagnosed with reflux, you're taking a PPI, and apple cider vinegar makes you feel better, you need to potentially rethink that PPI. Okay. I take Pepcid nightly to prevent GERD. Is it safe? Provide guidelines for diet and lifestyle changes to prevent GERD. Okay, so if you go to our website, gutbliss.com, and search in there, we have lots of stuff on, we've had blog posts and guidelines. If you go to the free gut guides under reflux, we have information there with dietary guidelines for reflux, how to taper off your PPI, etc. So we have a wealth of information on the Gut Bliss site. Please think about subscribing. As you know, we have no advertisers. We don't do anything with your information. The site is free. Myself and my Chief of Operations, Leslie Ann Berg, work on it on our time, but subscribers really help. So please think about subscribing. All you'll get in your inbox is every 2 weeks, you get the 3 new blog posts and the sort of what the office hours are for the month, and you can register early and make sure you get your spot. So that's it. Okay, and it's all there. So Pepcid nightly, Pepcid, famotidine, H2 blocker, not free, can cause some side effects, diarrhea, constipation, abdominal pain, muscle ache, fatigue. If you're not having any of those side effects, you're probably okay. But what I want to say to you is, do you actually need Pepcid every night? Because Pepcid works fast, or proton pump inhibitors are designed to be taken every day to keep the acid levels low. So they don't really work the same if you're taking them as needed. But antacids and H2 blockers can be taken as needed. So you could experiment. Maybe you could try taking it every other night. Maybe you could try taking it, only if you're having a larger meal or a later meal. Maybe you could try calorie shifting, having a big lunch and a really light early dinner, and seeing, do you need the Pepcid at all? Because while we know that Pepcid famotidine doesn't have NDMA, again, I can't tell you that 20 years from now, we're not going to go, oh, guess what? It did this, and this wasn't a good idea. So even though these drugs are not as potent as the PPIs, they're still blocking stomach acid. And, again, you need the stomach acid for digestion. So if you can get away with less Pepcid, better. Okay, another question. I'm female, over 60, overweight, have a large hiatal hernia, and I'm a longtime PPI user for reflux, and more recently, the hernia. Currently, my prescription is 40 milligrams. I no longer eat after 7. Yay, good for you. Sit up after meals, wonderful. And I'm beginning to move toward an anti-inflammatory diet. I love it. Good for you. One of my goals is to eliminate the PPI. Is scaling back the dosage a reasonable option? It's a great option in conjunction with your doctor. It's a great place to start, going from 40 to 20 milligrams and then thinking about it every other day. But I want you to make sure and talk to your doctor. I love what you're doing. You have given your stomach a curfew, so you're not eating late, sitting up after meals. I want you to think about adding a couple things. Think about sitting up after meals is great, but going for a walk after meals is even better because it's going to stimulate peristalsis, particularly that evening meal. So again, you're already doing some fantastic things, and I'm so pleased, but I want you, after your evening meal, to think about walking a couple blocks. You do not have to walk fast. You do not have to work up a sweat. You do not have to go far. Think about doing 15 to 20 minutes. That movement is going to stimulate peristalsis and going to help your stomach empty. The other thing I want to mention to you, you mentioned that you were overweight. Losing even 10% of your body weight can make a tremendous difference for reflux. Studies show that losing as little as 10%, and when I say as little, I realize how hard it is to lose extra weight. Believe me, I'm still battling my COVID weight gain, and I'm like, this stuff is sticking to me like glue. So I realize how difficult this is, but I want to encourage you that if you are 50 pounds overweight and you lose 5 pounds, it can still make a difference, okay? And you do not need to become, ideal body weight to improve the reflux dramatically. And doing that little walk 15 to 20 minutes after meals, particularly after dinner, will help with the weight loss. So I love the direction you're going in. Keep it up. Okay, could you address bile reflux and also the stomach acid bile acid connection? Yes, so let me address that quickly because we have a bunch more questions and 1 minute. I'll go a little over today. Bile reflux can be mistaken for acid reflux, and that is when the bile that is made in the liver, stored in the gallbladder, secreted into the small intestine, can come up into the stomach. And we can tell, symptom-wise, it's very difficult to tell. I would say virtually impossible, but we can tell on endoscopy. When I do a biopsy and I look and do the actual biopsies when I'm doing an endoscopy, bile reflux looks different histologically from acid reflux. So that's something that could require an evaluation. And I'm sorry, I don't have enough time to talk about stomach acid bile acid connection, but do get that evaluated. And I'm glad you mentioned it. Okay. So Lois wants to know, how do you get off PPI safely? Okay, so again, gutless.com, we have some great resources there for how to do that. Question, I eat a very high fiber diet and I'm always bloated. I take psyllium 1 tablespoon a day since I do not fully evacuate. Pelvic floor PT has not helped. I think that being bloated increases intra-abdominal pressure. Yes, it can, leading to regurg. I have a hiatal hernia and I'm not sure what to do. Okay. You have to be careful with the fiber. Fiber is amazing, but if you're eating it and let's say you have slow motility and it's not all going through, you may have to rethink how you're doing that. So maybe smaller amounts, right? Like I eat, yesterday I went for lunch with my daughter to this place I love in DC called Busboys and Poets. And I have my favorite salad there. It's a kale and quinoa salad. I have it with a little blackened shrimp. It is humongous. It's got kale and quinoa and fennel and apple and cranberries, and it is ginormous. And after I eat that, I'm really full. So I ate that at 1:30. Okay, I finished it at 1:30, and I went to my Vinyasa Flow yoga class at 6 o'clock. So that's 4.5 hours later. The upper limit of normal for emptying of the stomach is 90 minutes. I was regurgitating the salad. I could feel it. I have very slow gastric emptying. And so usually if I'm going to exercise, like if I'm going to my 6 o'clock yoga class, usually I would stop eating at like 11 and I would have really a big breakfast or a very light early lunch. But I had this huge salad at 1:30 and I could still feel it was, with a bending over for yoga. So, and that was a very high fiber meal. So not uncommon for the high fiber food. So what you might want to do is you might want to break the fiber up into increments, smaller increments. I still want you to eat a very high fiber diet because that is one of the most important things you can do, not just for healthy gut, but for healthy immune system. But think about, maybe less at one sitting. And you take psyllium, which is more fiber for evacuation. Think about maybe adding a little magnesium, a little cathartic later in the day to help move all that fiber through. And then of course, make sure you're washing it down with plenty of what, right? Also with a hiatal hernia, you don't want to overfill the stomach because some of your stomach is up in your chest. So you really may want to eat more frequent small meals and see if that helps. Okay. EOE was diagnosed from biopsy. I've lost weight, done elimination diet, including low histamine. I'll follow up with allergist. GI said to restore. Okay, fantastic. Thanks for that follow-up, Karen. So generous how you guys share this stuff with everybody else. Let me keep going through. Anal manometry. We'll do a whole other session on manometry, Holly, because an anal manometry is great idea if you have IBS, because you may have a condition like anismus and so on, but sort of bottom end. So it's hard to pack that in today, but I'll do a session on that for sure. Can SIbo, hi Anna, I miss you. Can SIbo in turn cause GERD because of the increase in gas that can push into the esophagus and open the LES? Yes, 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 absolutely. Small intestinal bacterial overgrowth, where you can have overproduction of methane, of hydrogen, etc. And Anna, as you probably know, because I think you and I discussed this, if you have methane predominant SIbo, not only is that more gas and potentially opening up the LES, but slow motility. So certain types of dysbiosis can decrease gut motility. And what happens if you have slower motility? Well, you have more opportunity for the products of digestion to sit there, plus the gas, and pop open that lower esophageal sphincter. So there's so much overlap between SIbo and GERD. And it's an important distinction, because if you go to the average gastroenterologist talking about this, they're just going to slap you on a PPI. And if the cause of your symptoms is actually SIbo, not GERD, that PPI is potentially going to make things worse. So thank you for pointing that out. Okay. I'm a low BMI person, 60 years old. So that's for those of you body mass index, so meaning lower weight with a healthy lifestyle. Get acid reflux. I've had manometry and impedance test. Both were normal, although the impedance test showed some silent reflux and acid reflux, but the score was low. Okay, good. Also have a small hiatal hernia. Any thoughts on what would cause the acid reflux? Yeah, it could be a little bit of slow stomach emptying, which might not have been picked up on either of those tests. So you could get a gastric emptying test, but another way to, because, you know, the problem with the gastric emptying test is they give you usually something to eat when you go for the test, like liver or oatmeal or egg or something like that, but it doesn't always mimic what you're doing at home. So what I would do, Rose, because you already, you know, not overweight, healthy lifestyle, all of that, had some good testing, nothing worrisome on the testing, is I would start to really split up the meals into smaller portions. Remember, the stomach is, you know, it's this big, it's really small. So try taking your average lunch and splitting it into two. Try eating smaller portions. Now, you don't want to eat such small portions that you're losing weight and, you know, having difficulty maintaining your weight, but even just separating them can really help. So see how that is. You know, practice is a Japanese term for it, for this art of like being a little hungry at the end of a meal. And that way, you know, you're not overfilling the stomach. And then, you know, I don't want you to be hungry all day, but then coming back an hour and a half, 2 hours later to finish up that meal. Okay. And seeing if that would help. Mentioned aging within. Is there a reason to attempt to slow it down? As a believer in running and plant-based eating is a direct connect to the speed of aging within. Well, Carrie, funny you should mention that. The last office hours for this month, which will be, okay, today is the 2nd, doing stomach acid. Next week is the 9th. We're doing fiber and COVID, which is really going to be general immune system, some fascinating new data, please come. But the 16th, which is 2 weeks from today, we're doing the microbiome and aging. And we're going to talk about aging internally and externally and some new data. And that's August 16th. And then the last 2 weeks of August, I'm not going to have office hours because I'm going to be in Turkey. So excited, never been. Okay. I was diagnosed with GERD. How is this different from acid reflux? Is diagnosis and treatment different? Marvin, thank you for asking that. Gastroesophageal reflux disease, GERD, acid reflux, heartburn, these terms are all used interchangeably. Heartburn more refers to just a symptom, right? But GERD and acid reflux, or GERD and reflux, are used interchangeably. There are technically, from a nomenclature point of view, there are some differences, but how we use them both medically and in the lay community, we're essentially talking about the same thing. Oh, James, you're so welcome. James is thanking me for my excellent educational outreach. I love doing this, James. And as I always say, I learn as much from you guys as I think you learn from me. Can autoimmune disease disorders affect stomach acid, especially as you age? I'm guessing maybe yes for conditions like Crohn's, how about sarcoid or celiac sporo? Do you have an opinion on bitters? So James, you're absolutely right. Autoimmune diseases can affect stomach acid production, but the biggest contribution is the development of something called atrophic gastritis, which I mentioned briefly before, which is really an autoimmune phenomena. So if you have Crohn's, sarcoidosis, those things, not a tremendous impact on stomach acid. Crohn's in particular, because the majority of people who have Crohn's have it in their small intestine and or colon. Upper tract Crohn's involving the stomach is very rare. It's in the order, less than 1%. Can have it in the duodenum. That's a little less than 5%, but stomach, gastric Crohn's is unusual. So Crohn's would be unlikely to impact it. Sarcoidosis similarly, but some of the drugs that are used for these autoimmune conditions like steroids can impact it. So it can be a secondary impact. And autoimmune condition, atrophic gastritis is an autoimmune condition. And so when you say autoimmune disorders, yes, there's even, again, the specific autoimmune disorder that can cause low stomach acid. I do like bitters, gentian bitters. So in Jamaica, where I'm from, Angostura bitters is a big thing. So you guys probably think of bitters more as something you put in a gin and tonic, right? Well, I mean, I'm not suggesting that you all are like big drinkers, but I mean, you as in current times, we think of bitters often as a garnish in drinks and cocktails. But where I grew up, Angostura bitters, if you're having any kind of gas, bloating, stomachache, like whatever is wrong with you in Jamaica when I was growing up, it's Vicks Vapor Rub on your chest and Angostura bitters in some water. That's pretty much, will cure anything as far as, our sort of Jamaican folk remedies, or some Cersei tea, we call a bush tea. So between Vicks Vapor Rub, bush tea, and bitters, we've got you covered. But in all seriousness, gentian bitters, I think, can be a great restorative for the GI tract. And, again, really not something harmful. So by all means, I recommend put a little bitters in some water and mix it up and see how you do, for sure. And also fennel, boiling some fennel, boiling a little bit of ginger. Ginger is great for motility for the GI tract. So if you're having reflux episodes, a little bit of fennel and ginger tea can help soothe things and help stimulate digestive enzymes. That's why at some restaurants, particularly some South Asian restaurants, you'll see the tray of fennel seeds that you can chew on or suck on as sort of a digestive aid. Okay. Oh my goodness, we're really going over. If you quit PPIs, what is the next step to treat your microbiome and help it flourish again? Christy, I would recommend that you go to gutlist.com, office hours in the navigation, the landing page, archived office hours, because we did a whole session on rehabbing the microbiome. You're going to find a lot of good tips there. Okay, so you know what? Oh, yes. Will I be doing a session on non-alcoholic fatty liver anytime soon? Absolutely. It's a really important one. Okay. I am so sorry, you guys. I would love to spend all day with you, but I do have to run, and I do want to be respectful of people's time because it is 11 after the hour. I know that fiber and COVID, like, can fiber protect you from viral illnesses? Does not sound sexy, but I promise you there's new data for that topic. And trust me, you do not have to become a vegan, but I really want to talk to you about how adding little touches of fiber in and how you can add them in. I made some soup yesterday for a friend of mine who has COVID, and I made some chicken soup for her, but I added a bunch of leeks to it because leeks are high in inulin, and how high inulin foods in particular can help, and max microbiota accessible carbohydrates, how important those are for immune function. So I'm not going to sit there for an hour and tell you eat more vegetables. It's going to be a little more nuanced than that. And then, of course, the microbiome and aging. We're all aging, fortunately, because the alternative to not aging is not being here. So as much as I don't love gray hair and wrinkles and other things, I am glad to be aging. But really new data on how we age both internally and externally, and the effect of the microbiome and what we can do. So do tune in next week after, subscribe gutlist.com so that you can see the office hour schedule right as we put it out, before we have them up on the website. And I wish you all a wonderful August. Take care.